All right. So thanks for having me back to continue our discussion of thyroid neoplasms, morphology, and genetics. I have a bunch of cases here, some of which I was going to give you guys on Friday, plus some bonus ones. On Monday. So, what I've done in the past in these kind of situations, and maybe we could try it here if everyone's internet works, is I can give you an overview of the case, but I could give you guys remote control of the screen so that you can, an individual person can drive it, because otherwise it's just me doing it. So we'll see if that works. So let's start with case one, which is a 31-year-old female with a 2.8 centimeter nodule that on gross examination seemed relatively circumscribed, kind of reddish brown. And so we have a representative virtual slide. So if anyone wants to be a guinea pig and do a remote control, I'm happy to give it to you. Don't all speak at once.
Yeah, I can try it if you
Thank you,
want
Mir.
to give me control.
Yeah. You have it? Nice.
Yeah, I think it's working.
Okay. Yeah, I see it moving and I'm not doing anything, so must be you.
Okay. All right. So it looks like a circumscribed nodule. White cellular. So sort of follicular-like structures. Papillary-looking nuclei. See the colloid. Anyone else have any comments?
So then what's your differential?
Can we see the outer surface, the periphery of the tumor?
Yeah, I was just getting there. Oops. There we go.
Looks like capsulated.
Yeah, at least pretty circumscribed.
So I don't see any like mushrooming of tumor cells through the capsule, although there is some over here.
These are normal thyroid follicles, so we don't see anything that is going out of it yet.
Right.
Yeah, no neoplastic cells going through it.
Right. Oh yeah, there's a little capsule there, yeah.
Yeah.
Mm-hmm.
So I guess papillary carcinoma is something on the differential, but follicular adenoma.
Mm-hmm.
Yeah.
And what's between follicular adenoma and papillary carcinoma?
I think maybe in terms of papillary carcinoma, maybe like a follicular variant of,
Mm-hmm.
of PTC.
Mm-hmm.
We just need to go more high power to see the nuclear features.
Yeah.
Okay.
We have already seen them. That was the first thing we did.
Yeah, I can show it again.
Maybe It's an FTP, but we don't see any capsular invasion or vascular invasion so far.
Right.
So we can look for nuclear features of PTC. I mean, there is some kind of chromatin clearing, but so far I don't see any nuclear grooves or obsidian inclusions.
Yeah, but there are also some like some cell nuclei have this marginal nucleoli.
I would
that,
say nuclear feature is kind of questionable, it's not very clear.
yeah.
They're
Yeah.
certainly wrinkled with some kind of crescentic formation, so the grooves are there.
Yeah, I think I see one groove. Yeah, there's one groove there. Yeah. So possibly there is a nuclear features of PTC. So which will be under categories of non-invasive follicular thyroid neoplasm with kind of papillary-like nuclear features.
NIFP, yeah.
All right, so we've got some votes for maybe follicular variant of PTC, maybe NIFP, maybe adenoma, but the nuclei are pretty robustly, I think, cleared. And yeah, I like those kind of cup shaped, those like semi-lunar shapes. Yeah, they're definitely grooves. I agree. I don't really see true pseudo inclusions. But all right, maybe I'll take the control back now for a sec. Thanks, guys. So, all right. So yeah, it's a circumscribed neoplasm with mostly follicles. And, you know, arguably, if you look around, you might be able to contrive maybe an abortive papillum here or there. There are a few of these follicle-like structures that have these tiny little protrusions right into the lumen, just tiny. So what do you do with that? This doesn't really have the super dense cytoplasm of a PTC, but it arguably has extremely cleared and grooved and cup-shaped nuclei. So is there anything else you might want to do to exclude or include a NIFT-P versus a PTC?
So we will do molecular.
Okay.
PTC will have BRAF.
Yeah.
Follicular will have more RAF.
Cool.
Do we need to? I was wondering if in a case like this, I mean, for me, I would consider like submitting more of the tissue.
So both of those answers are completely correct. And I'll show you both answers. So first, I'll show you the submitting of more tissue. So when you have a nodule that is really, you know, questionable, I would argue that, you know, these nuclei are pretty robustly irregular. And in these cases, you probably diffusely irregular, you probably should submit the rest of the lesion. And in this case, we did. And in this case, you can see here, there's a kind of a corner of a little bit of an unusual morphology. So when we go into this corner of unusual morphology, we see that the cells actually start to take up this more elongated follicular type of pattern, perhaps even with more elongated branching papillae, as you can see here and here and here. And the nuclei remain grooved and cleared and atypical and irregular. And so this, here's a nice area, right, where these papillae actually kind of develop, right? So you have one small corner where the papillae become much more well-developed. The cytoplasm becomes much more dense, like we would tend to think of for a papillary carcinoma. And I know there was a pseudo inclusion in here somewhere. I just can't find it right now. But the other thing that we have done, I mean, but that corner was very focal, very focal. The other thing that we did was BRAF immunostain. And so depending on your titration, it can be really weak. At this point in time when we did this stain, the titration of the BRAF was actually extraordinarily weak. But you can see that there's very faint staining in the neoplastic cells. And let me maybe see if I can find a darker area. Yeah, maybe here. There's very faint BRAF staining in the neoplastic cells. And we've since upped our concentration. And I will show you the nice negative control of the normal thyroid tissue. So because this was a little
Sorry,
bit.
Nicole, is the BRAF cytoplasmic stain or nuclear?
BRAF
or-
is a cytoplasmic stain, correct?
Okay.
Yep. So I don't have the positive control on here. I apologize, but yes, it's a cytoplasmic signal transduction protein. So you would be expecting it in the cytoplasm. And we did molecular confirmation. So we have predominantly follicles, rare abortive papillae. Oh, there's my pseudo inclusion. I have a nice picture of it there, but no invasion. So given the BRAF immunohistochemical profile, as well as our confirmation on molecular, this did in fact have a BRAF V600E mutation. There have been studies out there suggesting doing at least BRAF IHC on tumors that you're on the border between NIFT and PTC, because if it has BRAF, it absolutely should not be a PTC. If it has no BRAF, then you could consider it potentially to be a NIFT-P. Not that there are other PTC-like mutations that might be present, because there might be, but BRAF is your highest chance of getting an answer, right? So we really love our BRAF IHC. And so the other thing that was interesting in this tumor was that also in an incidental lymph node, there were actually lymph node mets with a little pseudomoma body in the lymph node, as you can see here. So I didn't show you that because that was going to give away the answer too quickly, but this was a PTC. So then what variant is it? Is it infiltrative follicular variant? Is it invasive encapsulated follicular variant? Well, not really, because it's not even invasive. Is it non-invasive encapsulated? No, because it's got lymph node mets. How did they get there? There must have been some occult lymphatic invasion. So I don't actually use the term follicular variant. I kind of say this is either a PTC with extensive follicular growth or prominent follicular architecture, which alleviates me from having to call it like one of these infiltrative or encapsulated follicular variants. And I sort of describe the morphology, describe what I see and say, hey, this is a PTC with a lot of follicular growth, and here's why I think it's a PTC. And so, this was formally how this chart kind of sorted out, was infiltrative follicular variant versus essentially encapsulated follicular variant, which is now NIFT-P. So again, I sort of call these PTCs with follicular growth and let it be. And really do BRAF on pretty much all of these that are on the border. I thought that was a very educational case, and both in terms of submitting extensively for morphology and doing immuno or genetics for confirmation. Does that all make
I had
sense?
one question. So
Mhm.
what percentage of the time do you think you order BRAF on these when you're considering NIFT-P versus just calling it NIFT-P?
Now that I have the stain, all the time.
Interesting. Thank you.
Or if we often have pre-op FNA with molecular. So if the molecular has an NRAS, I'm done. Like I just call it a NIFT-P, That's probably more frequent now that we're doing molecular on most of our FNAs that are suspicious, that are indeterminate. So I actually, if there's, as I said, if there's an NRAS or a PAX8 PPAR gamma or something like that, that's more of a follicular neoplasm, I don't do the BRAF. It's only in the cases that I don't have molecular that are in that spectrum of NIFT-P, I'll do it.
How often do you feel like you get surprised?
On occasion. So I'll show you some examples in this cohort that don't have BRAF and don't have RAS. Those are the surprises, because they, to me, are morphologically much more subtle. And we'll get to some of those. So
Thanks.
those are the surprises. Yep.
I have one question.
Mhm.
So between NIFT-P and follicular variant of PTC, do you see, like in this case, we have all the nuclei that had PTC features, but in NIFT-P, do you see some small population, or in that also most of the time the entire tumor is having those kind of nuclei?
So in true follicular neoplasms, including NIFT-P, the nuclear morphology can be much more variable throughout the tumor, like you're asking. So yes, sometimes there are areas that the nuclei are totally bland, like just round and regular and dark. And then you have a morphologic shift where some are more cleared. And then you have another area where some are more grooved and wrinkled. So yes, I think true PTCs, more likely than not, are going to have more homogeneous nuclear change. NIFT-Ps on occasion have more heterogeneous nuclear change, but that's not always the case. There are some NIFT-Ps where the nuclear change is diffuse. It just perhaps tends to be less more subtle,
Okay.
yeah. Oops. But there's never a good answer. It's definitely a spectrum. All right. So this is a second case, a 38-year-old lady with a 2.5 centimeter nodule. Does anybody want to try and remote control this?
I can.
Okay. Who's
Deshala.
from?
Deshala.
Hold
Yeah,
on.
Deshala.
How do you spell that?
DESOLA.
Oh, got it. Okay. All right. Can you do it?
Yeah, sure.
Great.
So here we see two pieces of tissue. Both of them look somewhat like they both have like these nodules in them, which look pretty much well circumscribed. It looks like there's something that may be a follicle, sorry, not follicle, capsule, like here, continue, but we'll go higher power to see. One of them looks somewhat like a little bit cystic. And from this power, it looks like, I mean, the architecture looks sort of papillary, but I'll go higher power to see if we see any like true fibrovascular cause. Can I? I can't zoom in actually.
No, there you go.
Oh, sorry.
Yeah. Focus maybe, yeah, on this top nodule. Yeah, good. Mhm.
Okay. So far, I mean, the follicles are not like very round, but I don't see any true papillary, like, yeah, papillae so far. Maybe like, maybe here, there's something, one little bit. Can see some giant cells here,
Mhm.
multinucleated giant cells, which we tend to see in PTC, but they're not specific.
Mhm.
So I'll just describe or look at oh yeah, this may be a good papillae here, papillum. In terms of the nuclear features, I mean, they look somewhat open. And again, we see a little bit of like nuclear irregularity, somewhat crescent shape here, and this one here as well. But then even in these areas, they're not very like, it's not very like powdery or open chromatin. So anyway, we have some features that maybe or maybe not. This one here looks a little bit very powdery and open here. So far, I do not see any grooves, convincing grooves like maybe here, but no pseudo inclusions. And if anybody has anything, if you see anything, just feel free to.
I think the quartz is kind of not thin and delicate. It looks like very kind of thick, I don't know, white. It's not, I'm not sure, is it true papillae or kind of pseudo papillae? That's another question. But there's nuclear features kind of clearing, as Deshala told us. Like, I think there's area of grooves kind of overlapping as well.
And then even, yeah, this looks a little.
These are somewhat crowded too.
Yeah, crowded, and some of them look like tall / columnar, like somewhere like here. So at this point, it looks like, I mean, in terms of differentials, again, maybe a PTC will be there.
I think the question is here, PDC versus an FTP. If this is kind of true papillae, that probably it is PDC. So I don't know, molecular will be helpful. With BRAF mutation, it's gonna be PDC. If it's RAS, then probably NFTP.
Can we see the capsule for
Yeah,
any
caps-
capsular invasion?
Yeah,
Or
that is true. We capsule.
I think there is area of kind of lymphocytic thyroiditis here, maybe.
Mhm, mhm.
Yeah, there's a focus of lymphocytic thyroiditis here. It's capsulated.
Yeah, I think that's just background, yep, and thyroiditis. Somebody-
Around a bit more.
Somebody took a chunk out of that capsule there.
Yeah, like here, this looks like good papillae actually. I mean, it's sort of elongated.
Yeah, so I think this brings up another dilemma, right? Another diagnostic dilemma in this differential diagnosis, because you certainly have some, nuclear irregularities that are papillary-like, and you have these questionable papillae,
Mhm.
so what are papillae? And I think this case highlights that existential question that, so does anybody want to vote, that these are true papillae? If you want to give me a thumbs up, and should be called PTC, or that are not true papillae and should not be called PTC. Does anybody have a strong preference either way?
It's hard because some look convincing and a lot of them have kind of a Sanderson-Pulser sort of look to them as well.
Right.
Is according to criteria, the true papilla should be kind of thin,
Mhm.
kind of coarse, which is with lined with what's the cells with nuclear features of PTC. That's from
Mhm.
understanding is true papillae.
Mhm.
Do we have some hidden lymph nodes in this case?
No, this is not a trick. This is definitely not a trick.
So from the look of it, it does not give you that papillary architecture. These cores, they have a lot of stroma in them and they have little follicles in them. I vote for no papillae, no true papillae.
Cool. All right, I'm gonna take the screen control back. Thank you all.
Yeah.
Yeah, so I think the technically, theoretically, true papillae should have thin, thin fibrovascular cores with good complex branching, rather than sort of these widened fibrovascular cores with some of them even have follicles in them, right? Like there's a follicle in this core. And so I think that the confounding factor in this case was basically just the nuclear features that started to be elongated and cleared and grooved and overlapped, et cetera. So, features outlined here, what do we do? So if these are true papillae, then it's not NIFT-P. If they're not true papillae, then you could consider NIFT-P. But again, because I'm a true believer in molecular, we did mutational analysis on this, and this had a KRAS. So we now have a follicular neoplasm with quote unquote hyperplastic papillae. So we, as I think you were all suggesting, or many of you were suggesting, so there is now in the new WHO a category of follicular adenoma with papillary architecture, right, with papillary growth. So conceptually, right, if you could have a RAS-driven neoplasm like a follicular adenoma with bland nuclei and papillary growth, why can't you have a follicular neoplasm with atypical nuclei that's RAS-driven with papillary growth? And I argue that you can. And this is this kind of hyperplastic papillary architecture rather than the complex branching, quote unquote true papillary architecture of a true PTC. And so I think that not only are the morphologic features of the nuclei overlapping, but the architectural features can also be overlapping. And so I think there's a lot that can be sorted out, question mark based on morphology, but certainly on genetics. And so we know that in the criteria, BRAF V600E mutation or any other high-risk mutations like TERT or TP53, right, as seen here, exclude NIFT-P. But nowhere in the NIFT-P criteria, right, is it actually discussed, excuse me, that a RAS mutation could support NIFT-P. As I told you guys before on Monday, I think this is now coming into the daylight in terms of people actually using RAS mutations to support a NIFT-P rather than kind of the converse of BRAF to exclude a NIFT-P. So I think there's more to be said about this in the future, but I think this is really, I think, critical in these cases that have morphologic overlap.
I
Comments?
had a question, Nicole.
Yeah.
So when you're using molecular testing in this context, how often, if ever, are you just doing BRAF versus doing a whole panel like you're showing here?
So here's my breakdown. If I don't have any known molecular testing from FNA, and I'm worried about a NIFT-P/PTC, I'll do the BRAF IHC. If the BRAF IHC is negative, but my morphology is a little too much, like if it's, maybe there's an undulating border, or maybe I can't determine if there's an abortive papillum, then I will pursue the molecular. So if it's completely circumscribed, totally follicles, nuclei are kind of in between on a line and the BRAF is negative, I'll usually stop there. However, if there's anything to me that's slightly more suspicious, for architectural or nuclear reasons, I will proceed with the molecular testing. And so I'm going to skip this next case. Is pretty much the same, is pretty much a recapitulation of the same. We have a pretty classic PTC here. So I'm just going to skip this, and then essentially a NIFT-P here in the same patient. So here's a BRAF V600 positive papillary carcinoma on one lobe and an NRAS positive NIFT-P on the other lobe. So I just wanted to show you this, to show you that these two things can coexist. You can have dual drivers in the same gland. So I'll give you, I'm happy to share these slides with you, by the way, if you want to look at them on your own. But I will jump now to some of these cases that highlight exactly that question, Ajit. So
Can I ask a question here?
Yeah.
Do you know if there's been any theories on how the BRAF itself causes the papillary formations?
That's a good question. No. And I don't know if there's some, the most I've read about this problem is that perhaps there's some cytoskeleton, some internal cytoskeleton disruption that might be affecting the cell polarity, and even the interaction of the cytoskeletal proteins with the nuclear membrane, right? That might cause the intussusception and the pseudoinclusions, but I don't think there's been an excellent understanding of why, but I think there's theories about some probably cytoskeletal.
And in the molecular profile of these, are there other mutations that are commonly seen in PTCs?
Yes, and we're going to get to those.
Okay, thank you.
The probably the most, let me see if I could, yes, I could annotate. Let me just annotate real quickly. Probably the most common mutations that are found in true papillary carcinomas that are not BRAF V600E are the BRAF fusions, so BRAF fusions, NTRK fusions, and then the RET fusions. Those are the most common. So interestingly, the other point mutations like the RAS mutations are going to be more common in your follicular neoplasms. And then what else? Probably the second most common is the PAX8 PPAR gamma. And then
RET and TRET.
yeah. So Well, RET fusion,
For medullary.
right, exactly. RET point mutation is going to be medullary. RET fusion is going to be papillary. And TERT promoter and TP53 are essentially morphology agnostic, but might be behaviorally, higher grade, if that makes sense. So this is how I like to think of them. If there's ever a mutation that we find that we don't know what it means, then we have to go to the literature and go to the TCGA study or do predictive analysis, but those are the most common ones. I did want to make a note that there is a RAS immunostain. This supposedly picks up the NRAS Q61R, but there are papers out there, by our friend Ronnie, who says that it could pick up other RAS Q61R mutations like the N's and like the K's and the H's. We don't have this immunostain, but it's theoretically out there. It won't pick up the non-Q61R though. Okay, so I'm going to move on to maybe this one. This is a 29-year-old lady with a 4.3 centimeter nodule. Maybe it's 8:30. And you guys want to drive it? Do you like it, or do you want me to do it?
Drive it. We can drive it.
Okay.
How many cases do you have more? We can look at the time and decide.
Yeah, why don't we, let's do one more that you guys drive, and then,
Okay.
okay. Do you want to do it?
Yeah, I can do it.
Hold on, I can't see your name.
It's Ansa.
Okay, thanks. Sorry, can you go to the top where there's the right arrow? Yeah, perfect.
So this one again looks like well circumscribed at low power, and here it is doing something going out of it, but seems like well circumscribed. Oh no. Okay. So here in this area that I am looking at now has kind of similar architecture we were seeing in the last case. And if I go higher to see the nuclear features, like this seems like a really good papilla. And the nuclei are not round, they have irregular border, and they have nuclear flaring too. So there is a calcification.
Yeah, it's hard to tell whether it's lamellated.
Yeah.
Yeah.
So
Pigment in the macrophages too. I wonder if this was previously biopsied and that's why it has kind of mushroomed out.
Yes, it was. I mean, most of these have been. Yeah, definitely this one was.
So most of these have round follicular structures and with the papillary nuclear features. And there was that little area that have more of a papillary structure. And let's see if we have a better.
area seems a little bit more cord-like.
Cord-like?
Less follicular looking.
Mm-hmm.
I don't know, trabeculars. Oh,
Yeah, they're definitely elongated follicles
right.
with these protrusions. There's some inflammatory background. There's that weird pooching of the capsule on the one side, but could that just be FNA? So I think, this case has, now we're building on features, right? We've got follicles, we've got these papillary-like structures. Are they true papillae or are they geographically folded follicles? I don't know. We have this area at the edge that almost looks like it could be a little mushroom. So I'm sort of I'm building up. What do you guys favor? Any diagnosis? What do you want to do?
NIFT-B and molecular.
NIFT and molecular.
What did the FNA show?
I mean,
Nuclear
it was like I think it was an indeterminate diagnosis, like AUS or even maybe suspicious for PTC.
Okay, and they didn't do the molecular
No.
testing. Okay.
No.
I
not
think
on
it
this
will
one.
have a BRAF.
Is there more? They look sort of branching though.
It's going through the capsule. It's kind of, as you said, mushrooming here. They're breaking up the capsule here, but it looks like kind of true papillae.
Mhm.
Can we look at that calc?
Calc. Okay. So this calc is also in that papillary area. So where was the other one? The other one was that. This is a good papillary structure.
Yeah. Yeah, I don't believe there was molecular on FNA for this one. I think that it might have been called suspicious. So they didn't do it.
Josh, did you find the calc you want to see?
Oh, it's somewhat unimportant. I think we can move on.
Gone. All right. So, hold on, there's one. Do you see that one? Right? Yeah. I think that's the same one.
Yeah, same.
Mhm.
Not
So
sure the
I
true one.
remember in your old lecture, you said that the true samoma bodies are in the lumen of the. Am I remembering it right?
True samoma bodies are in the papillary
In the papillary
core rather than the
Yeah,
lumen. So
lumen,
where's
yeah.
this?
This looks like in the papillary core.
Yeah, it looks like it's in the core, doesn't it?
Yeah.
It doesn't look like it's a calcification of colloid. So this might actually be real. All right, so all right, I'm going to take control back. So this awesome job. So yeah, I was quite concerned with this, especially because of this almost like mushroom shaped protrusion with this capsular kind of pinching, but the morphology was so overtly follicular. So I did the BRAF immunostain, it was negative. And then we did molecular testing and had an SND1 BRAF fusion. So when I looked back at the TCGA study, these BRAF fusions were found to more closely recapitulate the true BRAF V600E mutated PTCs. So it was thought that they were more on the BRAF V600E like spectrum. Therefore, we ended up coming down on calling this a papillary thyroid carcinoma. So the other point I will make, however, is that even if you call this a papillary carcinoma, it's relatively circumscribed. This one didn't have any lymph node mets. And so the question is, this could even be treated quite conservatively, right? So even if you're making a diagnosis of cancer, how big was this? I can't remember. 4.5. Yeah, so this was big. So the only factor in this case that might prompt treatment is going to be the size. And so the smaller it is, the more likely they are to not complete and observe. The larger it is, if it has mets, or if it has solid growth, or if it has any other features, the more likely they are to do completion in radioactive iodine therapy. So arguably in this case, I don't actually know I can't remember what they did for this patient, but in this case, size was probably the worst factor because there were no other high-grade features. So really, to me, it's a very much a combination of morphology, molecular, and other clinical pathologic parameters that might prompt completion thyroidectomy and radioactive iodine. It's not a single thing in and of itself. And so that's where getting all of your ducks in a row, having as much knowledge as you can, and having a good discussion with your clinical team, I think is really, really important, especially in cases like this. So if we're able to say, hey, there's genetic information here that suggests that this is going to be more like a true BRAF V600E like PTC. So let's call it as such, and then look at the other clinical pathologic parameters to determine if treatment is needed. So this was one of these rare cases that exactly, this was your question, Ajit, when do you pursue it? In this case, I pursued it. And in this case, I think it was helpful. So I'm going to have to go back and find out what happened to this patient, but that's the outcome. Are there questions or comments? Okay.
I guess my question is just like more philosophical, maybe like how much do you consider circumscription once you decide something is not in the sort of follicular neoplasm sort of group, you know?
Right. So circumscription can be meaningless if there are other features inside the tumor that show you otherwise. Just like that first case we saw, right? So I think it's as we're talking, it's not a single feature, right? Because you can have circumscribed carcinomas that are true carcinomas. I think it's one of many things you have to take into consideration. So yeah.
And then does circumscription become irrelevant if you have a lymph node met?
Yes. If you think the met is coming from that tumor. So I've seen cases where, for example, there's a circumscribed tumor that would, for all intents and purposes, be a NIFT-P, and then like a microcarcinoma in the background and a lymph node met. Well, in my opinion, the lymph node met is coming from the microcarcinoma, you know, not from the NIFT-P, and you can do genetics to prove it if you want. But that would be my only cautionary tale, right? Is if you have multiple lesions, you want to really be sure where that met is coming from, and does the morphology of the met recapitulate the morphology of the primary that you're suspicious about? If that makes sense.
Yeah, I ask a question here, please.
Mm-hmm.
So is this classical to get a lymph node biopsy, or I mean lymph node dissection with just like a thyroidectomy or lobectomy? I mean, just like if it's a previously diagnosed cancer, like on FNA or something like this, and the patient has lymphadenopathy, yeah, it makes sense. But I mean, just like in a general speaking, we don't get like a lymph node biopsy with the regular thyroidectomy, right?
So, right. So the only time they will do a regional lymphadenectomy is, as you said, if there is clinical or radiographic suspicion of metastases. They do not do prophylactic central or lateral neck dissections,
Yeah.
the absence. However, the most common thing that I will see is just incidental perithyroidal lymph nodes that kind of come out along with the thyroid that are part of level 6.
Yeah.
That they're not doing a formal neck dissection. They're just doing like, they take the lobe out and they happen to get some nodes. So sometimes in those nodes, there's tumor. So always, I think our gross prosectors, the residents and the PAs, sometimes are good about identifying those nodes, but sometimes they just get sectioned along with the rest of the gland.
Yeah.
So I would be very careful in that isthmic region to really, if you feel any fat or feel any nodes, try to submit those entirely, because those are your best chance of picking up anything if it's going to be there.
All right, thank you.
Yeah. Okay. All right, I'll do this one. 77-year-old lady with a calcified nodule. We can go through this one pretty quickly because you're going to see it has the same theme. But again, this is kind of almost a dumbbell-shaped nodule with kind of bilobed. There are some coarse calcifications rather than those fine semomatous calcifications. And we have nuclei that are somewhat grooved and somewhat overlapping. Again, predominantly a follicular patterned architecture. Maybe with some abortive papillae. Again, I'll provide these slides for you guys if you want to review them. Here, oh, maybe here's a papillum. Definitely some nuclear clearing. But this was challenging because it didn't have a very cellular growth pattern, right? The follicles are sort of similar size, right, to the background normal parenchyma. It's not actually that microfollicular, right? It's kind of a hybrid shape and size of follicles. So what do we want to call this one? I'll just tell you that this one had a RET PTC fusion. So I think these fusion cases, as I was mentioning earlier, are the ones in which, to me, the morphology is not quite as blatantly papillary, but the underlying genetics are thought to be BRAF V600E like. So I thought this was another interesting case of these tumors that were kind of on the verge, didn't really scream PTC, but then had PTC-like genetics. So I will send you guys the link of that for your own review.
When you say that it has like BRAF V600E like genetics, do you mean like the gene expression profiling of it?
Yes. Sorry. Thank you for correcting that. Exactly. So this is all from the TCGA study that says that we mapped both the point mutations and fusions and the gene expression profile. Exactly. And so we can coordinate that this fusion has a similar gene expression profile to those that are known BRAF V600E. Exactly. So it's more of a global milieu that matches. All right. 39-year-old lady with a 2.5 centimeter nodule. Sorry, I don't have a gross photo of this one. All right, I'll just drive around and maybe you guys can just tell me what you see.
It's also well circumscribed, capsulated. I think they're mostly kind of solid growth, maybe, I don't know, trabecular, kind of cord, maybe, something like that.
Yeah, for sure.
Yeah, it's not the like follicle that we see in other cases on this case.
Right.
There's a little bit of something in the capsule.
Yeah,
on
weird
the
nuclear features as well.
Oops.
Yeah, capsule somewhere there. Potential.
So it's still pushing, but I still inside the capsule, but I wouldn't consider this an invasion. Oh, maybe this is a vascular invasion.
Yeah. The cells look somewhat different though. Like there are areas
Yeah.
where it looks darker and then areas where it looks lighter. So I was wondering if we need to like look at the
Looks
different
more
areas.
oncocytic with abundant cytoplasm.
Right. Yeah, nuclear features kind of regular
Whereas
overlapping and
the chromatid looks like more salt and pepper. I don't know if it's just like
Yeah, so we have kind of this trabecular and microfollicular growth pattern of cells that, yeah, I totally agree with you. Have this really abundant granular pink cytoplasm and these nuclei that are variably small to large. Some of them have nucleoli, some of them have grooves. Somebody mentioned oncocytic, which I fully agree with. I think to me, these are more oncocytic type of features than PTC-like features, especially given the abundance of the cytoplasm and the you kind of get almost this random endocrine atypia look to me in a lot of these oncocytic neoplasms where you have some nuclei that are wildly larger than the others, some that are hyperchromatic. So to me, this is definitely more on that oncocytic atypia spectrum rather than the PTC-like nuclear spectrum. In my opinion, there's a nice kind of prominent nucleolus. So then what do we do about this focus over here? I would argue.
we need to
that's
see
not
if
a
it's just like
capsule.
true vascular invasion or not. Just like we have the characteristic of covering the endothelium, and if it's just like forming thrombi or fibrin clot.
Is this the only focus of invasion?
This is the only focus that, yes. Mhm.
It doesn't make it carcinoma.
I think it's true invasion.
So capsular versus vascular versus nothing.
It's in the capsule. I don't think it's the vessel.
If it's in the within the capsule, we don't consider vascular invasion. It should be outside of the capsule for vascular.
So you can consider a tumor to have vascular invasion of a vessel that is either in the capsule or adjacent, like just outside the capsule. So both of those types of vascular invasion are allowable. Usually they are kind of venous caliber, so generally somewhat larger rather than like the small lymphatics.
Can you see-
I go ahead.
Say, yeah, you were telling us something.
Oh, I was gonna say, I see a vessel here. Yeah, I see a
Yeah,
vessel
this is
here, but I
blood.
can sort of trace the outline of it. I can trace it,
Exactly, yeah.
trace it, and I think it loops back around. And so I
Mhm.
think this is a vessel that's against
Mhm.
rather than
Mhm,
within.
mhm,
So I personally don't think this is angio invasion,
mhm.
but I see that there's a capsule, right? I see that there's a capsule
Mhm.
right here. And to me, there's a focus, a nubbin, right, of tumor on the opposite side of the capsule that directly comes into contact with a normal non-neoplastic follicle, right? And so if I were to draw a line around this tumor, on low power, I think my line would be here. And this is outside that line. So I think this is capsular invasion because I see a capsule and I see tumor on the other side of it. And it is the cap, right? It's kind of the mushroom cap without the stalk. This is my opinion. I don't know what you guys think, but this is my opinion. I'm happy to argue, but you tell me what you think.
If you do like serial sectioning on here, could you eventually see a stalk?
You
Does that
might.
help?
So yeah, so I did serial sections on this and the nubbin persisted on the outside of the capsule. I don't think I ever found the stalk because maybe the stalk was cut right through, or maybe the stalk was on the facing, the facing side and it got effaced when we were facing the block, for histology or something. And so you don't always see the stalk. But if you see the cap outside the capsule, I would argue that that's evidence enough. The good thing is that this is still minimally invasive. Even if I call this a single focus of capsular invasion, this is still a minimally invasive tumor. To me, not an angio-invasive tumor. And so that's going to be the biologic driver of this rather than anything else. The lack of angio-invasion predicts indolent behavior. As long as there are no other things like solid growth, necrosis, mitoses, whatever, to me, this is an oncocytic carcinoma, minimally invasive. Do I have objections? It's fine if I do. And it had a PAX8 gamma fusion. So oncocytic tumors of thyroid rarely have the conventional genetics of follicular neoplasms like RAS, like PAX8 gamma. This was one of them. All right. So this, even despite its oncocytic morphology, had PAX8 gamma. Many oncocytic neoplasms, I think, as we may have mentioned last time, tend to have mitochondrial DNA mutations and copy number abnormalities rather than the conventional mutations. So if you don't find anything, right, don't be surprised in an oncocytic neoplasm. If you do find something like we did here, then at least you can be convinced that it's truly a follicular neoplasm rather than a papillary. Does that all make sense?
Mhm.
Okay. All right, 856. Cool. 17-year-old female with 4.8 centimeter nodules. So already on gross exam, there seems to be a potential like satellite out here, right? So I would really encourage your grossing to really look for these satellite nodules and submit them, because these are the kind of things that are going to be worrisome for invasion. this poor 17-year-old has this very cellular tumor that's growing in follicles that has, pretty stippled chromatin, like salt and peppery, not quite so PTC like. She has a lot of intralesional fibrosis here, these really thick fibrous bands. But the one thing I did want to point out here was this focus here.
Vascular invasion.
Yeah, so I think this is true vascular invasion. So this has a vascular wall at the periphery,
Fibrin,
and fibrin and adherence, right?
adherence, yeah.
Exactly. So you can follow the endothelium, in my opinion, all the way around this tumor. You can see the fibrin clot here, and you can see this fibrous, right? This fibrous adherence of the tumor thrombus to the wall of the vessel. And I think I'm kind of both top and bottom ends of it. So I think this is, for me, a classic, excellent example of true angioinvasion. So I would look for these plugs, right? Look for these plugs in the capsule or outside of the capsule. And so this kid has now an angioinvasive carcinoma that I believe is more follicular in nature rather than papillary, based on the architecture and the, relatively round nuclei. So this kid does have angioinvasion. We didn't do any molecular testing on her, but in these kids with follicular neoplasms, one may want to consider Dicer-1 testing follicular carcinomas, as these kids may have Dicer syndromes. I'll have to again follow up back on this patient to see if she ever had any testing. And then lastly, in the last 2 minutes, I did want to bring up this last point, which is an older lady with not older, 56 lady with a 5.7 centimeter nodule. Again, quite solid and fleshy, and maybe with some satellites over here, but really, really fleshy. And so we talked earlier about circumscription, and I think that is a challenging thing in thyroid neoplasms, because you can have areas of a really bad tumor that are focally circumscribed, and then areas that burst out. And in these cases, it's gross appearance and good sampling that will really help us make a diagnosis. So this tumor is a hybrid of follicles, right, with pretty bland, round nuclei, not enlarged, not overlapping, not elongated. And then areas over here that get much more solid and cellular, and almost trabecular, right, where you can't really see any follicles or maybe a few follicles, but really no stroma from wall to wall. And then some cholesterol clefts. And in the next slide, more wall to wall, right, just wall to wall solid growth without any stroma, with these kind of wrinkled, focally racinoid nuclei. Does anybody know what I'm getting at here? So we have wall-to-wall solid growth with racinoid nuclei, and if we're lucky, we'll have what I'm trying to get to here in the corner. Oh yeah, here it is. If you're lucky, we'll have necrosis.
Poorly differentiated.
Yeah, exactly. So this tumor is deceptive. Oh yeah, here's a nice area of punctate, beautiful punctate tumor necrosis, surrounded by these kind of almost cribiform-like areas, cribiform and solid areas. So I think you really, really have to sample well these fleshy tumors, because if you may only see, you may only see this and be like, oh, that's nothing. But once you start to see anything that has any kind of solidity to it, any kind of wrinkling or racinoid nuclei, just keep submitting, because you're likely to find potentially worse players. So we ended up calling this a poorly differentiated carcinoma. This actually may be a focus of angioinvasion. I can guarantee you that at some point in this tumor there was definite invasion, but yeah, this is poorly diff. And so I know it's 901. This had both NRAS and TERT promoter. So we think that TERT promoter mutation is a soft indicator of necrosis, and necrosis is a soft indicator of TERT promoter mutation. So if you ever see tumor necrosis, I would be really, really cautious. And so there's a new category in the WHO of high-grade follicular-derived thyroid carcinomas that includes both the conventional poorly differentiated thyroid carcinoma that were developed in the Turin criteria, but also to include the non-poorly differentiated carcinomas that did not meet the Turin criteria, but these differentiated high-grade carcinomas that were defined based on the MSK criteria. So, you know, poorly diff has to have solid growth, and it has to not have PTC-like nuclei. Differentiated high grade can be of any growth pattern of any nuclei, but what's common is the fact that all of these tumors have increased mitoses or necrosis. All right, so now the presence of increased mitoses and or necrosis in any thyroid carcinoma is now considered to be bad, right? So whether it be truly poorly diff or diff high grade is less relevant because the prognosis is thought to be quite similar. Worse than well diff, not as bad as anaplastic. But it's thought that the ones that are morphologically poorly diff generally tend to be RAS driven, and the ones that are diff high grade tend to be more often BRAF driven. We'll see if that pans out in the future now that we have these two different criteria, but I would familiarize yourself with these because I think they will be really important for patient care now that we have these criteria. Comments, questions?
Is there any different treatments to this different type of carcinoma?
So the primary treatment for most carcinomas, whether they be PTC, poorly diff, high grade, is generally total, / completion thyroidectomy with consideration of radioactive iodine therapy. So RAI is usually frontline. The only time they will start to consider anything more than RAI frontline is when there is some more aggressive features like bulky disease in the neck or metastatic disease, or now there's even some consideration for if it's tending to be on the poorly diff or high grade or anaplastic spectrum and has these bad clinical disease, they may jump to a targeted therapy. For example, if it has an NTRK rearrangement, they may jump to an NTRK inhibitor. If it has a BRAF mutation, they may jump to a BRAF inhibitor frontline if it has these clinically aggressive pictures. But generally, RAI is always the thing that is at least considered upfront, and then it may diverge based on other indicators. So in patients who have clinically bad disease, we are often asked to do the molecular testing because they will consider a targeted therapy if a relevant mutation is present. What else?
Thank you very much, Dr. Cipriani, for the 2 sessions, for your time and efforts, everything.
You're welcome.
Yeah,
Thank
thanks
you.
a lot. That was very, concise and insightful, as we always expect from you. And I think, very enlightening to hear your approach on things and kind of your insights that you've developed over the years and seeing all these cases.
Thanks. It's been fun. Almost 10 years of seeing nearly all the thyroids at the U of C has been really educational for me. So
A lot of
always happy to
thyroids.
love thyroid.
We have yet to see your cats.
Oh my gosh. All right, hold on.